Hello, students. So now we are going to talk about the third division of the trigeminal nerve, sometimes known as the mandibular division of the trigeminal nerve, or V3. V, cranial nerve 5, the Roman numeral V is 5, and 3, Arabic numeral 3, number 3, for the third division. So this is the largest division of the trigeminal nerve, and it's the only mixed division. So when I say mixed, I mean that there's a portion of the nerve that's sensory, that senses things. I'm poking you, I'm pinching you, I'm stroking you on the chin. And then there's a smaller portion that is motor. So that has to do with movement. We're chewing, innervating those muscles of mastication. And the trigeminal nerve exits the skull through the foramen ovale. Sometimes when I remember this, ovale, I say oval 3, kind of rhymes, 3 ovale. So that's how I remember the third division of the trigeminal nerve exits through the foramen ovale. Kind of reminds me of 3. So the anatomy of the mandibular division of the trigeminal nerve is that the sensory and motor nerve roots, they form a common nerve trunk just beyond the foramen ovale. So the nerve itself exits and is combined together in a common nerve trunk just outside the foramen ovale. And then we have several branches. So this kind of reminds me of a tree, right? We have a trunk and then we have branches. And nerves are kind of like that. They have big, thick trunks, and then the branches kind of spread off the trunks. And then sometimes you could have little tiny, tiny little nerves off the ends of those. And those are like kind of like the leaves. So we have a thick trunk right outside the foramen ovale. And then we have several small branches that branch off or leave that common trunk. We have the meningeal, and that is sensory to the meninges. And the meninges are those membranes that cover the brain and spinal cord. It's kind of like that sac that the brain is housed in. And then we have the motor branches, and those motor branches that branch off go to the medial pterygoid muscles and also 2 tensor muscles in our oropharynx. We've talked about that before, and those 2 tensor muscles are the veli palatini muscles, which tenses the soft palate and allows us to make those velar consonant sounds by having the tongue touch the stiff palate, and also the tensor tympani, which is within the ear. And that helps us to sort of open up our eustachian tubes and kind of remove, like when you try to kind of pop your ears when you're in a plane. So then beyond the common trunk, V3 then divides into a smaller anterior division and a larger posterior division. So the anterior division contains 1 sensory branch, which is the long buccal, and then 3 motor branches, the remaining muscles of mastication. So we saw that in the other motor branch that came off the common nerve trunk to the medial pterygoid muscle, right? Now this branch, this small anterior division, innervates the other 3 motor branches, the remaining muscles of mastication, lateral pterygoid, temporalis, and masseter. Then we have a large posterior division, and we have sensory branches, the tongue, TMJ, and the mandibular teeth. And then we have 1 efferent branch, and that goes to the mylohyoid and the anterior belly of the digastric. And those are our accessory muscles of mastication, are suprahyoid muscles. And this just shows you some of the branches that we'll be talking about and the mandibular nerve V3, the auriculotemporal. So that's going to be near our temporal bone, or our temple and our ear. Lingual, that might mean tongue. Inferior alveolar, inferior, lower, the mandible, the mandibular bone and teeth. Mylohyoid nerve, that's the floor of our mouth. Mental nerve, chin. And long buccal is, it actually, you would think that it means cheek, but it's the cheek portion of the gingiva down by our mandibular molars. So our anterior division of V3, we have that one sensory branch, the long buccal. Can we see it here? Here it is. Here's our long buccal. And what do you think is the name of this muscle here going this way? This is our buccinator muscle. And we also have 3 efferent or motor, which is the remaining muscles of mastication. So we have a lateral pterygoid nerve, we have deep temporal nerves, and we have a masseteric nerve, masseter. So those are the other branches that innervate those remaining muscles of mastication. So here is another view. So let me just go back here. So this was like a lateral view of the skull. And you could see here the mandible, like the masseter muscle's been removed. Some of the buccinator has been removed. The mandible has been cut, right? You can't see the condyle, the coronoid process coming up here. So that's been kind of cut away. So this is a lateral view. Let's orient ourselves on this view of the mandible. So this is the tongue side of the mandible right here. So this is the lingual of the mandibular teeth. Part of it that's hidden to us, this would be the buccal portion of the teeth on this side. So this is the medial side of the mandible. This is where the mandibular foramen is. This is where the mandibular division, or the inferior alveolar nerve, enters into the mandibular foramen. Our condyle, our mandibular notch, our coronoid process, our coronoid notch here. So this is a sort of an internal view. We call it medial view. That you could also see the long buccal, sometimes just referred to as the buccal nerve, coming across here on the other side of the ramus. And then let's see, we have the masseteric nerve. We see the deep temporal nerve. So those, we cannot see in this view the lateral pterygoid nerves. This is just a different way to look. So again, lateral view. These are the motor branches of that anterior division that supply the remaining muscles of mastication. So this is pretty self-explanatory. The masseteric nerve supplies the masseter muscle, right? When it contracts, closing the mouth. The deep temporal nerves supply the temporalis muscle, again, closing the mouth. Lateral pterygoid nerve supplies the lateral pterygoid muscle, and that opens the mouth when the muscles contract. Think of the rope pulling, right? This large masseter, when it's pulling up like this, it's pulling the jaw closed. Same with the temporalis muscle. It pulls towards the origin, pulling the mouth closed. And the long buccal, the sensory branch of the anterior division. So the long buccal itself passes between the 2 heads of the lateral pterygoid muscle. So let's go back. 2 heads of lateral pterygoid. We have a superior head and we have an inferior head. Superior head attaches to the disc. Inferior head attaches to the coronoid process. They pull at the same time. Those lateral pterygoid muscles pull, carrying the disc and the coronoid process down so that we slide down, opening the mouth. The long buccal nerve itself passes through those heads, And then it says, let's see, descends inferiorly and anteriorly on the medial of the ramus. What does that mean? It just means it goes down and forward, crosses over the anterior border of the ramus behind the molars, basically where the retromolar pad is. And then it enters the cheek through the buccinator muscle. Now, it doesn't supply sensation to the buccinator muscle. The facial nerve, cranial nerve number 7, does that. So what am I talking about here? Here is the long buccal. The long buccal is descending inferiorly, comes down, anteriorly, forward, right here over the ramus. Now, here are the mandibular molars. This right here, of course, this is bone, not soft tissue, but if we were looking at someone's mouth, this would be the retromolar pad right here. And the long buccal nerve kind of comes very close to the surface at the retromolar pad, and it supplies the tissue, right, the soft tissue, the buccal gingiva of the mandibular molars. That's what the long buccal nerve supplies. That's of interest to us. It also does the skin of the cheek and the buccal mucosal membranes. So what do we care about this long buccal nerve? Well, we care about it because this nerve has to be anesthetized. It needs to get numb when we're scaling in the area of the buccal tissues on the mandibular molars. Some injections, right, cover a whole lot of teeth. The inferior alveolar that we'll talk about in a couple of minutes covers a whole lot of teeth, gets a lot of the pulps of the teeth numb. But we still need to get that soft tissue on those mandibular molars when we are scaling a quadrant on a patient. So that covers our anterior division of V3. And now we're going to be looking at the larger posterior division with the 3 sensory branches to the tongue, TMJ, and mandibular teeth, and then the 1 motor branch to those suprahyoid muscles, the mylohyoid, and the anterior belly of the digastric muscle. So we spoke a little earlier, like right beyond the common trunk, V3, separates into the smaller anterior division and the larger posterior division. This is that medial view of the mandible, the tongue side, showing all the different branches, the 3 sensory branches that go to the tongue, the lingual nerve, the TMJ, the auriculotemporal nerve, and the mandibular teeth, which is the inferior alveolar nerve. That 1 efferent branch, or the motor, is our mylohyoid nerve right here. So all in red. So this is the posterior division. Here, the larger posterior division, including 3 sensory branches and 1 motor branch. In the yellow here, this is the smaller anterior division that we already talked about with the long buccal coming this way. So the 3 sensory or afferent branches, the auriculotemporal nerve, the lingual nerve, and the inferior alveolar nerve. And the 1 efferent branch is our mylohyoid nerve. So the auriculotemporal nerve gives us general sensation to the parotid gland. So if I poked you in the parotid gland, the auriculotemporal nerve would tell the brain, something's piercing me, ouch. It also gives general sensation to the TMJ and the skin of the ear in the temporal region. So the lingual nerve. So in some of the views I've showed you, we're looking at the medial or the inside of the ramus. The lingual nerve runs down and forward along the medial of the ramus, right? We talked actually about that in a prior slide about how the long buccal kind of comes down and forward on the medial of the ramus. However, the lingual nerve stays on the medial side. It doesn't cross over to the lateral side of the jaw. But the lingual nerve runs just forward and towards the midline of the inferior alveolar nerve. The inferior alveolar nerve, for those of you that are dental assistants, right? That's like I'm giving a mandibular nerve block. You're doing the inferior alveolar nerve. Now this nerve is deeper and more lateral to the lingual. So a lot of times when someone is getting numb, and you've probably maybe even experienced this, even if you're not a dental assistant, if you've just been numbed up in an office, you'll notice that your tongue gets numb. Half of your tongue gets numb. So who cares? Well, it's important, right? Because sometimes a patient will say, you'll think to yourself, gee, only my tongue's numb, my teeth aren't numb. So what does that mean? It means that the needle wasn't placed deep enough to get the inferior alveolar nerve, because that's what makes the teeth numb. The lingual nerve makes the tongue numb. So when the patient reports just the tongue is numb, they didn't go deep enough to get the inferior alveolar nerve. If you've gone deep enough and you get the teeth numb by hitting or getting right before the inferior alveolar nerve, the lingual nerve just gets numb because it runs close enough to the IA, inferior alveolar nerve, so that the tongue gets numb as a consequence of doing the IA nerve block. We'll talk a little bit more about this in class, and you're going to have many, many lectures about this in local anesthesia class. And I'm going to show you with the pipe cleaners what that looks like and why sometimes the teeth don't get numb and the tongue gets numb in class. Anyway, so then the lingual nerve, it joins together with the chorda tympani branch of the facial nerve. And these fibers are intertwined. So a lot of times patients will say, yes, their tongue is numb, but then their taste, because chorda tympani supplies taste for the anterior 2/3 of the tongue. So sometimes if you've ever been numb, like for me, it feels like I'm tasting metal sometimes as it's like wearing off. And that weird taste is called dysgeusia, is because branches of the facial nerve, that chorda tympani that supplies taste sensation for the anterior 2/3 of the tongue, is also numb. All right, so here is a lateral view. So here is the inferior alveolar nerve. This is what's getting the teeth. This is what we just talked about, the lingual. So it's in front of it, and it's a little bit closer to the midline than the IA. So when someone is coming in with the needle, they'll reach the lingual nerve first. If they don't go deep enough to here, teeth aren't getting numb, right? But if they go all the way to here, get this one numb, IA numb, the molecules of anesthesia will diffuse across and get the lingual nerve. And then also little branches of that chorda tympani, which gives people like a weird taste. I especially get that as the numbness is wearing off. So area supplied by the lingual nerve, general sensation, I'm pinching your tongue, right? Not taste, that's chorda tympani, facial nerve, general sensation of the body of the tongue, lingual gingiva of the mandibular teeth, general sensation, right? If I poke you in the submandibular or sublingual salivary gland, and then also the mucosa of the floor of the mouth. So if you're doing an extraction, right, you kind of want that lingual gingiva to be numb, all right, especially if you're kind of tearing it open a little bit. So you will want to get the lingual nerve in addition to the inferior alveolar nerve numb. So I keep talking about the inferior alveolar nerve, and here it is. We're going to talk about it. Okay, now, so it descends down and forward between the sphenomandibular ligament and medial aspect, that inside aspect of the ramus. So it is lateral to the outside and posterior behind. It's behind and to the side of the lingual nerve. It enters the mandible through the mandibular foramen and travels through the mandibular canal. The inferior alveolar artery and vein also enter here. So what's the big deal? Who cares, right? Nerves, veins, arteries all travel together. Well, the big deal can be as you're anesthetizing someone, you're wiggling, right? You're getting that needle through, do, 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 and you're right where you should be, and you get the nerve numb. Sometimes, like you just little poke on the artery, and so the person will end up with a bruise. Not very often, but it happens sometimes. It's usually the vein, it shouldn't be the artery. So that's why it's important to know that nerves, arteries, and veins run together. And unfortunately, that's why people can end up with black and blues after getting numb. It's because the arteries and veins run very close to where the nerves are. All right, so it runs inside the mandibular bone to this canal. The nerve is inside, and then right where the mental foramen is, the hole near the chin, mental foramen, chin hole, the nerve splits. And it splits, the inferior alveolar nerve splits into two separate nerves, a mental nerve and an incisive nerve. So the mental nerve actually exits out of the mental foramen. It comes outside. The incisive nerve is just a continuation of the inferior alveolar nerve. It just stays inside the mandible. The difference between the two, when a nerve exits a foramen, such as the mental nerve is exiting out of the foramen, it only gets soft tissue. When a nerve is inside the foramen or stays inside a canal, it means it gets teeth and pulp and bone. All right, exits foramen, soft tissue. So here it is. Here's our inferior alveolar nerve. Right here, that is our lingual right here. Two important ones. Oh, and here, I want to show you this. So look at this. Inferior dental plexus, right? So we got this. Where is it? Inferior alveolar nerve. It's entering the mandibular foramen. Here's the canal. And look at all these branches. Do you see this dental plexus? These are the nerves going to the teeth. All these are like the leaves, right? The tiny little leaves. We got trunks and limbs or branches. These are the tiny little leaves leading to the teeth. Here is the mental foramen. Pop, here comes the mental nerve. Basically, the inferior alveolar nerve splits here, exits out, mental stays in. We call it the incisive nerve. So the inferior alveolar nerve is now named the incisive nerve beyond the level of the mental foramen. Once it passes the mental foramen, we call this the incisive nerve. Oh, we talked about this, the dental plexus, right? So these are all the little teeny nerves supplying all the teeth, right? All the way up. So the inferior alveolar nerve supplies the pulp, right? The pulp, the soft inner chamber of the tooth. That's the thing that can only feel pain. It doesn't feel anything other than pain. And it also supplies the periodontium. Now, buccal gingiva over the molars, remember, is supplied by the long buccal nerve. So we go all the way up, gives off dental plexus to mandibular molars and the second premolar. So right about where the mental foramen here is, that is where those plexuses stop, and then it becomes the incisive nerve. Look at this. Oh, someone's open nice and wide here. We got nice and wide, and we are seeing the pterygomandibular raphe, this kind of line here. Now, this is the buccinator. So this is formed from the buccinator coming here and our superior pharyngeal constrictors coming here. They come together in this sort of ligamentous. It's like a ligament here called the pterygomandibular raphe. And that is one of our landmarks for our inferior alveolar nerve block. Oops, wrong side. Let's do the mental. All right, talked about this enough, right? Mental nerve, continuation of the inferior alveolar. It exits the mandible at the mental foramen. Soft tissue only. The lip, the chin, but we want pulp, right? Incisive nerve. That's it. It remains in the canal, and it supplies the dental plexus to the mandibular first molars and anterior teeth on one side, right? So we split, we're in the half here, right? So we have the left side and the right side. So it doesn't go like across the midline, ends at the midline. And in fact, there's some cross innervation usually at the midline. So people will tend not to be numb on this mesial surface of the canine, the central. All right, now, one thing, I'm not trying to blow your mind. I'm going to blow your mind a little bit. So when we talk about trunks and the branches and the leaves, the same thing with anesthesia. So the inferior alveolar is thicker than the mental and the incisive nerve. So if you numb the inferior alveolar, you will end up getting the incisive and the mental because you've gone higher up on the trunk. It's like if I needed surgery on my foot, on my toe. Well, they could put a little local in my toe. They could do that, right? And do my little surgery on my toe. Or they could give me like, what is that thing that mothers get in their back? An epidural, right? They could give me a large epidural in my back. It would get my toe numb, right? Everything else would be numb below the level of the epidural. So the same thing happens with the nerves, with the teeth, right? You get the IA, right? That's kind of like the mini epidural. Even if you just wanted to work, let's say, on the canine and the first premolar, it would get a lot of things numb. So sometimes people will do the incisive, but because as hygienists, we tend to work in quadrants. When you're doing scalings, you're doing them in quadrants. We want that kind of big bang for the buck, meaning we want the epidural. We're not just doing a tiny toe, we're doing all those teeth. So we tend to use the IA nerve block way more than any incisive or mental. Mental, forget it. That's just soft tissue, right? We want to get those pulps numb so we could scrape those teeth. So if you opt and say, well, I'm going to just do the incisive nerve block, well, you're not going to get any molars. You're just going to get from the first premolar forward to the midline, right? And that, we usually don't do that kind of work. And you're not going to get the lingual gingiva because the lingual nerve is not close to the incisive, it's close to the inferior alveolar. We'll talk a little bit more about that, and we'll work with pipe cleaners to show you how the different nerves run and why you have to do some injections based on quadrant dental hygiene. Oh, mental foramen, there it is. All right, so the mandibular nerve supply, we have the inferior alveolar nerve that also splits into the branches or the leaves, not even the leaves, we're going to say tiny branches, the leaves of the dental plexus that supports or supplies all of the teeth. That's the mental nerve, the incisive nerve. Then we have the lingual nerve, and we have the long buccal nerve. Mylohyoid nerve. So this is the only motor or efferent nerve in that posterior division, and it branches off just off the eye before the IA nerve enters the mandible. And this supplies the mylohyoid muscle in the anterior belly of the digastric, those suprahyoid muscles. Let's review. All right, mandibular division. It's the only one that's mixed. It's both sensory and motor. It leaves the skull through the foramen ovale. It enters the mandible through the mandibular foramen. And it includes the muscles of mastication, that's the motor aspect of it, and the lower teeth on one side, right? We have a right and we have a left. I've already talked about this a million times, I'm not going to talk about it again. So you can read that, but the anterior supplies and the posterior supplies. It has another way to look at it, what it supplies, what's getting numb. And I'm going to have a handout that you're going to look at that's going to tell you what supplies, what, nerve sensation, sensory, motor in class. All right, that's V3. Hooray!